Dr. Khanna prepared this presentation with a bunch of cases, a bunch of questions that basically go over main LI-RADS categories, and we'll just, without breaking the microphone, we can do some cases, and they all going to have some scenes for you to take a look at. All right, so case number 1, 71-year-old female with HCV cirrhosis with 2.3 by 2.1 centimeter lesion in the liver. And this beautifully demonstrates one of the most hated ultrasound signs in my book, posterior acoustic enhancement, which we rarely see in cysts, but we see quite often in solid liver masses, like in this case. So tell everybody don't use it, but some people still do. All right, dual screen, contrast enhanced ultrasound image, grayscale with the tumor, injecting bubbles. So that's the end of the arterial phase. You can start seeing portal veins filling up with contrast in about 27 seconds. It's very typical to see such a heterogeneous appearance of the liver on contrast-enhanced ultrasound in cirrhotic patients. So this is normal liver surrounding the tumor, and then patients take a breath in, lesion kind of goes away from the field of view. Those are representative images of the arterial phase of the lesion. And then late images at 1, 2, 3, and 4 minutes after contrast injection with arrows pointing to the tumor. All right, so the question is, what LI-RADS category would you assign this lesion to? All right, you can just write it down and we'll go over things. This is a table if you need it. Just for a second to refresh your memories, because I know it's complicated, but it was 2 centimeter lesion in the patients with risk factors for HCC. So it's definitely not something benign, right? So we can go straight into 3, 4, and 5 diagnostic table. 3 important questions to answer. How big is this lesion? It's 2.3 centimeter. With arterial phase hyperenhancement, so it takes you into the last column. Was there washout present? Yes, and it happened at about 3 minutes after contrast enhancement, so this is definite HCC LI-RADS 5 category lesion. Yes? To which?
This is an example, to my mind, where there's some technical challenges. So there's no question that there's hyperenhancement, right? Okay, I agree with that, and I don't think that that's got any pattern to it. Now this becomes difficult. So at 1 minute there's no problem, I don't think, because it's iso-echoic, iso-enhancing to the rest of the liver. But this is a really good example and something worth talking about. So to be perfectly honest, like when I look at that 4-minute picture, I don't like that picture because the lesion is down, but the liver's down, and the lesion's no longer well demarcated, and so you have to be unhappy. Now the 3-minute picture, I'll take it. But I think it's a really good thing to talk about a little bit. So that's kind of like a case where if you're not completely happy, then sometimes it's better to back off, and you always want to back down. And so if you weren't sure, like let's say for example you didn't have that 3-minute picture and you just had the 4th, well then I might do something like back off one, like always go to the less confident diagnosis, and if you want to go to the more confident diagnosis, you have to be really confident.
Agree. So we just talked yesterday, and a couple of months ago I came up with a brilliant idea how to solve this problem, and Turned out Stephanie been doing this all along without telling anybody. So if you have cirrhotic livers, the contrast degradation will be much higher compared to normal liver patients. Would you agree? Probably because of the liver sinusoids are tighter, there may be increased pressure, maybe those bubbles go through too much to survive, who knows. But we do see significant degradation of contrast enhancement in the liver in cirrhotic patients. So when I have cases like this, I always do second injection, and I do not scan until 3 to 4 or 5 minutes after contrast injection. I'm preserving all microbubbles, let them circulate, undisturbed, untouched, and I know nothing will happen until 3 minutes. So I know there is no early washout. I re-inject, I don't scan until 4 minutes after injection, and I go back. And when I go back 4 minutes after injection without scanning, liver will be full of contrast, and all those lesions, which I know where to look for already, will demonstrate you mild washout. So that's a trick that we just started apparently with.
Absolutely imperative, and so I remember way back when we started to do this, is that you have to always think what are the questions that you're asking yourself. And so if you know the answer to what does it do in the arterial phase, you don't need to look at that again. And especially because you burn off quite a bit of bubbles when you're scanning continuously. Now, the thing, unfortunately, though, is some livers are so poor, like if you were in a real screening program where patients have been around, they've had previous treatments, that even when you try that, the perfusion of the liver can still be down. But I totally am supportive of doing that. So you just inject and you wait, and then you peak on the portal venous phase, and you've got to make sure you're in the right place.
So one of the things for this that we ask our sonographers to do is we ask them to keep their hand with the transducer on the patient in the window that they used for early scanning. Because if you take your hand off, turn around, go have a cup of coffee, and you come back and you will be looking at this patient like you've never seen this patient before. So I cover with my hand freeze button because their immediate knee-jerk reaction after I said contrast image complete, they start acquiring imaging. So I cover the freeze button so they can't do anything. But they ask them to hold their hand on the patient, so when we do need to go back, they're already on the lesion, and this helps tremendously. All right. You see, we turn an easy case into something more exciting with absolutely no time. All right, 44-year-old female not feeling well with something that looks like this in her liver that doesn't look right. So it's a combination of not feeling well and not looking right together. All right, arterial phase hyperenhancement of this thing that is not looking right in the liver. And you can see normal liver enhancing at the bottom, and this quite prominent arterial phase hyperenhancement of this lesion. This is the lesion at 38 seconds, demonstrating rapid washout, occurring less than 1 minute after contrast injection. All right, so the question is, what LI-RADS category would you assign to this lesion? History provided is 44-year-old female not feeling well. It would be nice to have some suspenseful music on the background. All right, so the answer actually is none of the above, because remember that LI-RADS, I'm not saying this is normal liver and nothing to liver, but LI-RADS categories are only assigned to patients at risk for HCC. Okay? If there is no risk factors for HCC, you cannot use LI-RADS. You just tell them this is a highly suspicious lesion with malignant features of arterial phase hyperenhancement and rapid washout. So these, practical scenarios will have to go to biopsy. All right, case number 3, 61-year-old man with cirrhosis, has the lesion in the deep portions of the liver. You can see contrast arriving into the vessels. enhancement of the liver, arterial phase with arterial branches enhancing. So this was just screenshots, and honestly, I quite often look at my cines like this. I go back to the scanner and I roll cine frame by frame by frame by frame. And I always use dual calipers that are available in most of the scanners, and I measure my lesion on a grayscale, and I look what it looks like on contrast-enhanced ultrasound. Okay? So doing this, in my mind, is very, very helpful because my brain doesn't work as fast as some others. I cannot see everything I need to see on those cines, so I always do this frame-by-frame analysis. So you can see this lesion has a little bit of arterial phase hyperenhancement, and then it starts washing out at 46 seconds, and then at 2 minutes, it demonstrates more prominent washout. So which category would you assign to this lesion? All right. Yeah. So again, take a look at this table. I think this lesion fits the LI-RADS M categories very nicely. It has kind of it has arterial phase hyperenhancement, maybe with a little bit of a rim morphology, and it demonstrated very early washout that you can see occurring at 46 seconds after contrast injection. So this is LI-RADS M. Go to biopsy, find out what it is. All right, the biopsy showed HCC in this lesion. So was contrast-enhanced ultrasound wrong? Yes, it was wrong because HCCs should be LI-RADS 5, or no, it was correct because LI-RADS M includes HCC, and it was correct. Because remember, LI-RADS 5 is HCC, but it will not pick up 100% of HCCs. Poorly differentiated HCCs, cholangiohepatomas, MATs, and cholangiocarcinomas will all go into LI-RADS M category, and we need to biopsy them because we're not 100% sure those are HCCs. But actually finding HCC in LI-RADS M category is correct and appropriate. All right, case number 4. 74-year-old man with NASH cirrhosis, diagnosed with HCC on biopsy 2 weeks ago at South Hospital, admitted with abdominal pain, swelling, SBP, blah, blah, blah. Ultrasound looks like this. Giant tumor in a liver, echogenic material in a portal vein that does not demonstrate definite flow. Maybe there is a little bit of flow along the periphery of this lesion. Honestly, I would struggle with this. I know that tumors will supposed to have portal vein tumor thrombus, but quite often those patients have significant portal hypertension, and they develop portal vein thrombus, just blunt thrombus quite often. And presence of a little bit of a flow along the periphery can be seen in chronic portal vein thrombus because they get recanalized, and you might end up with a small flickers of color Doppler flow along the periphery. So to me, this is totally indeterminate. I would kind of worry about tumor thrombus because this portal vein looks distended, but again, acute gland thrombus can look like this as well. All right, so contrast-enhanced ultrasound, you can see a tumor in here, and that's your portal vein at the bottom of the image. Probably gonna play it once again so you guys can see early phases of this. So arterial phase hyperenhancement of the tumor that blends in into the surrounding liver at, what, 23, 24 seconds. And this is quite interesting. It demonstrates a very important feature of HCCs and arterial phase hyperenhancement. It's transient. In some tumors, it lasts only 2 to 3 seconds. So if you're not careful, you might miss it, because if you get off this lesion, allowing patients to take deep breath in or something like this, you might miss arterial phase hyperenhancement, because again, sometimes it lasts only a few seconds. To help with this problem, we always ask patients to take a breath in and hold it about 10 seconds after contrast injection. In very cirrhotic patients, I might wait until 15, because I know that bubbles will arrive to liver at about 10 seconds in normal liver patients and about 15 to 20 in patients with cirrhosis. So when I see the first bubbles, patients already took a breath in and he's holding. In the beginning, we would ask patients to take a breath in after we inject contrast, and by 15 seconds after contrast injection, they run out of breath. And when I need to get those 5 seconds of early arterial phase hyperenhancement, they start breathing, catching their breath, complaining about how inhumane I am by asking them to hold their breath for so long. So this ruins your life completely. So practice breath hold with them before you inject bubbles, and then about 10 seconds ask them to take a breath in, stay in the lesion, get the first 20 seconds of arterial phase hyperenhancement, and that will give you the best images possible. All right, this is a little bit messy image, but this is the tumor, portal vein with something in it, arterial phase. You can see that portal vein enhances simultaneously with arterial phase hyperenhancing portions of the tumor, and normal portal veins are still hypoenhanced because it's too early for them to enhance, and then later you see enhancement of the tumor and enhancement of the material in the portal vein. And later on, you can see washout in the tumor and some washout in the clot. So this is classic appearance of the tumor in vein or malignant thrombus in a portal vein. And I'll let Stephanie maybe comment on this, but in my experience, recanalized blunt thrombus in the portal vein almost always leaves some areas unenhanced. Right? You're going to see some channels running through in a portal vein phase, but there will be some clots still remaining in there. It's hard, yeah, but if you see something like this distended portal vein with arterial phase hyperenhancement, and timing is the key, because the difference between arterial phase and portal vein phase in liver, sometimes 5 seconds, sometimes 10 seconds. So you can see the blush of contrast arriving into portal vein seconds after arterial phase hyperenhancement of the tumor and seconds after arterial phase hyperenhancement of the clot tumor thrombus in the portal vein. So for all practical purposes, it's super important to stay on that portal vein and arterial phase so you can see enhancement of the tumor component before blush of contrast arriving into the main portal vein. But still can be challenging and tricky, especially with small clots. I do personally struggle with this. So contrast-enhanced ultrasound criteria for tumor in vein, unequivocal arterial phase hyperenhancement, and washout of soft tissue within the lumen of the portal and or hepatic veins, and it must correspond on dual screen with mass in the vein. And again, those dual calipers and going slice by slice through your cine is extremely important. Tumor in vein does not necessarily mean HCC. It can happen with cholangiocarcinomas and also cholangiohepatomas as well. So honestly, if it's not associated with LI-RADS 5 lesion, if it's LI-RADS M and tumor thrombus with biopsy, sometimes both, because we had some surprises when you have cholangiohepatoma or cholangiocarcinoma in the liver and then HCC thrombus in a portal vein. All right, case number 5, 79-year-old male with cirrhosis, liver with hypoechoic tumor. You can see arterial phase hyperenhancement, portal veins are filling in. And this is one of the very nice examples where a sonographer or physician is scanning along the axis of the liver motion. So whatever happens with the respiration, tumor stays in your field of view. Quite often people scan perpendicular to the liver, going by intercostal spaces, and then you're going to see your tumor getting in and out, in and out, in and out of the field of view, and you might miss important things. So even though you might end up with some shadowing along the edges of your screen, I strongly recommend scanning, or at least start scanning in the sagittal plane. So when liver moves, this lesion will be in a field of view. If you absolutely cannot do it, if you have to have transverse approach, if you have to stay in intercostal space, then do breath hold. Practice, do very shallow breath holds and try to time it appropriately so you can get arterial phase hyperenhancement, and then you can go back and do washout. All right, this is the screenshots from the arterial phase of this contrast case. You can see the nodule. And interesting thing about this nodule, it's early on surrounded by this crescent of decreased enhancement that later fills in with contrast, but some of the portions of the tumor still remain relatively hypo-enhanced. This is the late phase of this study. At 1 minute, nothing, 2 minutes, nothing, and at 5 minutes, you can see some washout of this lesion, which appears late and to a mild degree. So with this table, how big? 2.3 centimeters, hyperenhancement, yes. Washout, yes. So this is classic LI-RADS 5 lesion. However, this is a very specific appearance that we use as an ancillary feature for malignancy that's called nodule. In nodule, you can see hyperenhancement of the relatively larger nodules with some parts demonstrating lower enhancement. We don't know for sure, but our kind of consensus opinion is that is early HCC in a dysplastic nodule. So all of this combined thing is probably a large dysplastic nodule with a focus of HCC growing into this thing. Nodule and nodule. Question is, how do we measure? Do you measure just hyperenhancing portion of the tumor, or you measure the whole thing? And I think most of us will measure the entire nodule because you can use this larger diameter for your characterization. Nodule and nodule is ancillary feature. How do you use it? Can you upgrade LI-RADS 3 to LI-RADS 4? Can you use it to upgrade LI-RADS 4 to 5? All of the above, or only A and C? It doesn't really apply to this case, but if you see arterial phase hyperenhancement and you do not see washout, you cannot use nodule and nodule as ancillary feature to upgrade it all the way to LI-RADS 5. Again, we want to be very, very strict with our characterization. This will upgrade LI-RADS 3 to LI-RADS 4. But this nodule fortunately had washout, so we can give the LI-RADS 5 and move on. I think we're running out of time for lunch, and I don't want to hold you.
Thank you. That was great fun. So